on to Creating a Family. Talk about infertility and adoption. Today we're going to be talking about intrauterine insemination, also sometimes known as artificial insemination. Important topic. I hope you enjoy it. This show is brought to you by Creating a Family. We are the National Infertility Education and Support nonprofit. I'm Dawn Davenport, your host and the director of Creating a Family, and you can find us and all of our resources online at creatingafamily.org. Faring wants you to know about a free app actually. Ferticom is the title of the app. You can get more information about it at their website, ferticomapp.com. This app was designed by two reproductive psychologists to treat women and couples who are struggling to get pregnant. And they are using cognitive behavioral, as well as relaxation techniques, and they suggest specific techniques to use to women to handle specific trying life situations that come up. In fact, they offer over 500 different coping options, and they identify somewhere over 50 specific situations that have a potential to cause distress. It's a good app. It's free. Get it. ferticomapp.com. This show, as well as all the resources provided by Creating a Family, and we do have a lot of resources, could not happen without the generous support of our partners who believe in our mission of providing unbiased education and support to the patient community. A few of our wonderful partners include Cooper Genomics. They are a reproductive genetic testing laboratory focused on providing genetic tests and services for every step along your fertility journey. They offer carrier screening, PGS, PGD, and non-invasive prenatal screening for individuals and couples. And they also offer screenings to be used during IVF and early in pregnancy. Cooper Genomics, and this is really important, they also have comprehensive genetic counseling and counselors to help you interpret your results, and that is actually very important. Another partner we have is Reproductive Medicine Associates of New Jersey. They are a recognized scientific and patient care leader in the field of infertility. They have 10 offices and 21 physicians at last count throughout New Jersey. They maintain an IVF delivery rate well above the national average, and we thank both of them for their support. Today we're going to be talking about intrauterine insemination. You will also hear it or see it written as IUI, or even hear your doctor talk about IUI. Sometimes it's called artificial insemination. And it's often the first step in infertility treatment. It's also, of course, used for single moms or lesbian couples. What can you do to increase the odds of success, which success, of course, is getting pregnant from IUI? Today we're going to be talking with Dr. Marcy McGuire. She is a reproductive endocrinologist at RMA New Jersey. She is also the clinical professor of reproductive endocrinology at the Robert Woods Johnson Medical School. This is a re-airing of a show that we did a number of years ago. Again, important topic. The information is, as they call it, evergreen. And so often what we're finding is that we have shows that are buried in our archives, and they are too good to miss, so we periodically whip them out when we're not able to record a new show for you to hear. I hope you enjoy. Dr. McGuire, welcome back to Creating a Family.
Hi, thank you for having me.
Yeah, as I mentioned, IUIs can be used as part of infertility treatment, but they're also used by single women and lesbian couples who are using donor sperm. And we're going to be talking about all of these on today's show. I'm going to want to start with reading a question from Carolyn. She sent us a question that kind of gets us started on the how IUIs might be used as part of fertility treatment. She says, my husband and I haven't been able to get pregnant. We've been trying for 2.5 years. I'm now 33 and he's 38. They haven't been able to find a reason for us not getting pregnant. We look perfect, which is kind of weird. Do we automatically start with IUI? So that kind of leads us, Dr. McGuire, into the question of what type of diagnosis is most often helped with either IUI and IUI versus some other type of fertility treatment such as IVF.
Absolutely. So artificial insemination itself, the process involves taking the partner's sperm or donor sperm and washing it to remove some chemicals or portions of that called prostaglandins, which could induce an anaphylactic reaction if not removed. It also helps to purify the sample so that there's really only the best moving, best sperm in the sample. That sperm is then placed via a tiny catheter directly into the uterus, and this is beneficial because the vagina is very acidic. It has a lot of mucus in it, and typically during intercourse, most of the sperm sample is actually lost in the vagina. So we can kind of maximize concentration of healthy sperm through doing an artificial insemination.
What percentage of sperm doesn't make it through to the cervix, through the cervix, and into the uterus in typical intercourse?
So to be honest, I'm not sure of the exact percentage, but the majority of it does not make it past the vagina. Okay.
So by bypassing the vagina and the mucus in the vagina, it gets directly into the uterus, and from there, where does it go?
And from there, the sperm actually stays in cervical crypts and other sort of housing areas, if you will, within the uterus, and it slowly, some of them will swim up towards the egg, and ultimately the sperm does fertilize the egg in the fallopian tube. The embryo that results then kind of floats back down the fallopian tube and into the uterine cavity to implant. So it is a bit of a complicated process, but at least bypassing the initial part should get the sperm closer to the egg.
So what type of diagnosis, infertility diagnosis, is most often helped with IUI?
The very best diagnosis, or the diagnosis which is most helped through IUI, is actually cervical factor infertility. So for women who've had a LEEP or a cone biopsy or other surgeries on their cervix, these are surgeries that are commonly done for abnormal pap smears. Those women have an even less receptive cervix for sperm transport. So that can be a physical blockade itself for the sperm to get into the uterus and ultimately meet the egg. So to bypass the cervix in that way is very helpful, and those women tend to have a very high pregnancy rate just from artificial insemination alone. That being said, artificial insemination is used for many different other diagnoses, including unexplained infertility. Its efficacy for unexplained infertility is debated, and certainly use of artificial insemination alone probably doesn't offer a dramatic improvement in pregnancy versus just timed intercourse in couples that have completely unexplained infertility. Another diagnosis that you could consider using artificial insemination for is very mild male factor infertility. So there are certain parameters within a semen analysis that physicians look for to ensure that couple would have a good chance of conception via either timed intercourse or artificial insemination. So generally there needs to be at least 15 million sperm per milliliter of fluid. The motility needs to be better than 50%, so more than half the sample should be moving. There are certain volume parameters and shape parameters as well for the sperm. So if there's a borderline concentration issue, you may get some benefit from, again, kind of taking out the weaker sperm, concentrating it and putting it directly into the uterus rather than letting some of the sample get lost in the vagina. There are other parts of the semen analysis, for instance, the sperm shape, which is not aided by doing an artificial insemination. So it turns out that human eggs are surrounded by a rather thick membrane, and sperm heads need to be perfectly shaped to kind of wiggle their way through and fertilize the egg. So if the sperm shape generally is not perfect, maybe they're more round or there's two heads or for whatever reason they're a bit misshapen, then just simply putting the sperm closer to the egg is not going to solve the problem of the sperm actually getting into the egg and fertilizing it. So,
that makes sense. One of the problems, however, is that at least in the past, certain insurance, and let's be honest, a lot of people don't have insurance that will cover a fertility treatment, but assuming you do, certain insurance have required in the past, it's almost as a mandatory first step that you try X number of IUIs before they will consider paying for IVF. Is that still something you see?
Yes, and it's actually a pretty interesting requirement. So yes, regardless of well, that's not exactly true. Unless there is a dramatic factor such as very low sperm count or blocked fallopian tubes, which would justify your argument to allow a couple to go directly to IVF, a lot of insurance companies will require sometimes 2, 3, or 6 artificial insemination cycles before approving moving on to in vitro fertilization. It's an interesting phenomenon, especially in light of some recent literature that was published on the topic. One in particular called the FAST trial was conducted in Boston. And that looked at both the pregnancy rate per cycle and the cost effectiveness of having patients move from Clomid directly to IVF versus having patients move from Clomid to artificial insemination to IVF. And it turns out that moving from Clomid directly to IVF is much more cost effective, with about $10,000 less spent per delivery, and has a higher per cycle chance of pregnancy than taking that longer stepwise route. So based on that study, perhaps insurance companies should rethink their requirements, but at this time I do see a lot of insurances requiring an IUI as an intermediate step before IVF.
Yeah, it's a very interesting thing, and we're going to come back and talk about some different things that are related to that in just a bit. But I wanted to touch on, we've got questions from single women considering using donor sperm as well as lesbian couples, so I kind of want to touch on that before we get into more of the detail. Let's see. This is a question, actually she didn't give her name. So I'm a single mom to be and will be trying to get pregnant with donor sperm probably at the beginning of next year. Is it better for me to have the artificial insemination done in the uterus or cervix, IUI versus ICI? So let's talk about, and that would apply with lesbian couples. We actually have a similar question from Shana. And that's the first part of her question. It was asking the difference in pregnancy rates between IUI versus ICI, and then she also asked if there was a significant difference in cost between the two. So let's talk about intrauterine insemination versus intracervical insemination.
Absolutely. So they're actually very similar procedures. The biggest difference is that the sperm has to be washed more thoroughly for an intrauterine insemination out of fear for that anaphylactic reaction that you can have if the prostaglandin content is too high in the seminal specimen. So they're just the specimens are processed slightly differently, although often physicians will use a IUI processed sperm specimen to do an intracervical insemination too, just to play it safe. So that's the biggest difference between the procedures. Now, in terms of pregnancy rate, the pregnancy rate with artificial insemination is slightly better than with intracervical insemination, and really there's not that much difference in what the patient experiences. There's still a speculum exam, there's still a catheter. It's just a matter of the catheter moving forward by a centimeter or two rather than being just right at the cervix. So in my opinion, it is worth it to go through with the full artificial insemination if you're at the point where you're going to do an intracervical insemination.
Because really the only difference is where the catheter stops, whether it stops right at the cervix or whether it pushes through the cervix and goes into the uterus, right?
That's correct, and it's not a difference in pain or anything like that. Most patients have no pain at all with an artificial insemination. Gotcha.
So it's just, it's only a matter of how hard you push. I realize it's a little different from that, but still.
Yeah.
Okay. Shana had some other questions as well. Now, she says, my wife and I will be using donor sperm to start our family. All right. She's asked the questions about IUI versus ICI. She would also says we would really like to do a home insemination, but don't want to if our odds of success are lower. So that's a different form of artificial insemination. Can you talk some to that? We often call it home insemination, and that tends to be a popular option with certain same-sex couples, lesbian couples.
Absolutely. So with a home insemination type of procedure, the sperm or the semen specimen is deposited directly in the vagina, and there is not an effort to place it in the uterus itself. This can be done at home, so it can be more of an intimate kind of procedure or an intimate happening between the couple, which is appealing, I think, as you said, to many same-sex couples. I think it's perfectly fine in a couple that is otherwise fertile, so have good numbers in terms of their ovarian reserve. There's no known issue with the uterus or the fallopian tubes being blocked. I think it's fine in that case to try home insemination a couple of times prior to coming in to the office for the more medicalized procedure of an artificial insemination. Of course, in any circumstance, you'd want to be careful that the sperm specimen that's being used has been properly screened for sexually transmitted diseases, etc.
And don't you think, if depending on the age of the couple or the woman who the woman who's trying to get pregnant, that you need to give some thought to how long you ought to try home insemination or any lower odds of success method, just because time is not on your side?
Absolutely, and certainly in a woman that's older than 35, I wouldn't spend too much time with the home insemination route, only because time is not always on your side, and you wouldn't want to waste precious months on a treatment that wasn't as effective. Also, the sperm specimens themselves can be quite expensive too, so that can be costly to go through a number of different home inseminations and then inseminations in the office too.
Right. You are listening to Creating a Family. Today we're talking about intrauterine insemination and how you can increase your odds of success. Creating a Family has the largest infertility and adoption communities on the social networks, and we would love to have you join us. There are 3 ways to connect with us on Facebook. Of course, we have our Creating a Family page, which you can find at facebook.com/creatingafamily. We also have a very large, very active, and very supportive support group. It's a closed Facebook group, so you'll have to request to join, and only those within the group can see the post. You can find that at facebook.com/groups/creatingafamily. And you can also connect with me personally, and I am Dawn.Davenport1. And we love Pinterest around here. We also love Twitter, and you can find us on both of those at Creating a Family. All right, now I want to talk some, and it's one of those interesting things when we talked about the insurance issue requiring IUIs. It's always struck me as interesting because once you've moved into, or once you're doing an IUI, you have the choice of medicated and unmedicated IUI cycles. And then with medication, I think you have the choice between oral meds and injectables. So I want to talk some about that. Do you generally start with an IUI on oral meds by Clomid or Femera or whatever people are using?
It depends a lot, actually, on the diagnosis coming into it. So for women with anovulatory infertility or polycystic ovarian syndrome, Clomid is a wonderful medication, and there wouldn't be a need for the IUI without the Clomid. So we typically would start with the Clomid IUI, and those couples have a pregnancy rate of about 50% in the first 3 months of trying. So that works really very well. In women or couples with unexplained infertility, the pregnancy rate with IUI alone is not really different than the pregnancy rate with timed intercourse. And actually, the addition of Clomid does not necessarily have a dramatic impact on improving the pregnancy rate either. So for couples with unexplained infertility, I do recommend to move directly to gonadotropin artificial insemination, or FSH IUI, which is the injectable medicine. In those couples, the pregnancy rate with IUI alone is about 4 to 6%. The pregnancy rate with Clomid IUI is 6 to 8%, and the pregnancy rate with FSH and IUI is somewhere in the neighborhood of 15 to 20%, depending on obviously other factors. But it makes sense in that group to move directly to the injectables within artificial insemination.
And this is unexplained infertility.
That's right.
Gotcha. All right. So that kind of begs the question of how do we define success when we talk about IUIs? And I'm probably preaching to the choir here, but I certainly we say this a lot on our shows and throughout our website, is that the goal from any form of fertility treatment is one healthy baby. And one of the concerns with what you're calling FSH IUIs or IUI with injectable gonadotropin medication is the risk of multiples. So I wanted to talk some about that. What is the risk of multiples when you're using injectable drugs?
Absolutely. So the risk of multiples with injectables is about 20%. And that makes sense because the basis for the treatment is the idea that these couples who have been having regular intercourse with the release of one egg each month have not had conception. So the idea behind giving the injectable medicine is to purposely make them ovulate 2, 3, 4 eggs per month to improve the chance of conception, of course coupled with the artificial insemination as well. But if you're having a woman ovulate 2 or 3 eggs each month, then it makes sense that her risk of twins would, or even higher order multiples would be higher, and it's approximately 20%.
What about people with PCOS? Because we hear about some of the more famous recent multiples. The Kate +8, I believe she was PCOS with injectable, and some of the other large, some of the Quints, more recent. In fact, probably a lot of the higher order multitudes have resulted from women receiving, and at least some of them I know were diagnosed with PCOS. So what about PCOS, a woman with PCOS going through a IUI cycle with injectable ovulatory stimulating medication?
Absolutely. So women with PCOS often actually can be pretty tricky to maintain, to monitor and to control their ovarian response to the injectable medicine. They'll often be resistant, or their bodies will be resistant to the medication initially, and their estrogen level won't budge, no follicles grow, and then all of a sudden they hit a magic point and their ovaries take off like a rocket ship and 5 or 6 eggs grow. So it is absolutely imperative that all women, but especially women with polycystic ovarian syndrome who are having COH-IUI or FSH-IUI, the injectables, be monitored by trained physicians so that if, in fact, they do get 5 or 6 eggs to grow, their doctor can say, hey, you know what, this cycle isn't working out. There's too many eggs here. It's not safe to proceed. The alternative to doing that is to proceed and then have a fetal reduction procedure, which essentially means if there's more than twins, to reduce that number of fetuses to 2. But ideally, the physician will be watching closely with daily or every other day monitoring so that the medication dose can be adjusted in an effort to have really only one egg be released in those women with PCOS, where the issue is not that the sperm and the egg aren't meeting, but that the egg isn't being ovulated at all.
And so the monitoring is done which way? Is it vaginal ultrasound?
Typically, a transvaginal ultrasound and also a serum estradiol level, just to make sure, again, that there's 3 or 4 follicles, no more than that, and that the estrogen hopefully would stay less than 1,000 picograms per mil.
But the reality for couples that I think sometimes they don't think about ahead of time is that a significant cost associated with fertility treatment is in the medication, in the injectable medications, the gonadotropins. So by the time you have spent a fair amount of money getting these injectables, then if your body does overproduce eggs and then you have 5 or 6 eggs and your doctor suggests that you cancel the cycle, you're out boatloads of money oftentimes, multiple thousands of dollars usually. So how does that work at that point? How receptive are people are to just saying, okay, well, that was let's just scratch the cycle at that point?
Right, absolutely. It can be incredibly frustrating, especially for, like you said, women with polycystic ovarian syndrome who initially had very resistant ovaries and were on the medication for days and days with no response, when all of a sudden a profound response is seen. I've seen many tears shed, but I think when you show the patient all the follicles that are there, and she's seen the shows about multiples, and she knows sort of the consequences of both to her and the babies of having so many, then I have never had an issue where the patient really refused to cancel this cycle when it's indicated.
What about at that point, people will ask, can we switch to an IVF cycle where you go through the egg retrieval? Okay, I've grown all these eggs. I've produced all these eggs. Can you just go in now and harvest these eggs? And let's use them, let's say we'll do IVF. Is that an option?
So it is, and some insurances will be receptive to that and allow the patient just to convert it over to IVF. Of course, the cycle wasn't set up exactly how it would be if we were just trying to do IVF from the get-go. So sometimes the follicle development is a bit dysynchronous. There's a cohort of 6 or 7 eggs that are bigger and the rest are smaller. But depending on that particular patient's response and their willingness to try to move on to IVF, that does make sense in some cases, especially, as you said, not to waste that effort for the medicine, the cost of the medicine, and all the monitoring to that point.
Well, to say nothing of having gone through having to the wear and tear on the woman's body. That at least then if you can, but the timing. At that point, is it possible to do a fresh? Is the timing such that you're off sync with the window of implantation that you may not be able to do a fresh cycle?
So it depends, and often they actually can do a fresh cycle still. The implantation window is relative to the time that the uterus was initially exposed to progesterone. So as long as they haven't ovulated, typically we can still do a fresh transfer as long as the estrogen doesn't get too high. And in these women that are very what we call brittle polycystic ovarian syndrome patients, and the estrogen gets high kind of at the drop of a hat, then we would often freeze the embryos, not for dysynchrony, but for risk of ovarian hyperstimulation.
Yeah, that would make sense. And of course, this also begs the issue that the couple can afford IVF, right. And can afford, assuming that insurance is not paying for it and they're paying for it out of pocket. They have to make the decision if they can afford it at that point.
That's right. Yeah, and it does become tricky. I think in couples that are paying for fertility treatment completely out of pocket, IVF can actually make sense in them for the reasons that we had talked about before with the FAST trial, and that the per delivery the cost per delivery is lower in women who go right to IVF. But for couples whose insurance only cover artificial insemination, it does become very tricky, and those are the women who are more inclined to cancel, I believe. Yeah,
because at that point it's being covered. So, in your opinion, is it possible to do a medicated with injectable medication, IUI cycle, what you called an FSH cycle, with low enough odds of multiples if with experienced monitoring? Is it possible to do it safely?
It's possible to do it safely to some degree, I guess, with a caveat or an asterisk, only because twins themselves are not always safe, and you've talked about this plenty on the show too.
Yeah.
While most twins do fine, they deliver early more often than singletons, and certainly the greatest tragedies I've ever seen are couples who try for so long to have a conception and then they conceive twins and they're so happy, but later face a devastating delivery, early delivery, or mm-hmm. problems in the pregnancy related to having two.
We underestimate most twins are born healthy, but the reality is, if you look at the stats, just cerebral palsy alone, I don't know it off the top of my head, but it's significantly greater risk for twins versus singletons, as well as other complications. So, yeah, tends to be a bit of a frustration, and I understand it from the patient standpoint that there's a lot of draw to the idea of an instant family, but we try to educate people that there comes, but you have to weigh the risk to your instant family and to you as well. So and that's one of the big concerns we have with IUIs, particularly if it's with injectables. You are listening to Creating a Family, talk about infertility and adoption, and today we're talking about intrauterine inseminations and how to increase your odds of success. We are really glad to have you with us. We primarily keep in touch with our audience through our weekly e-newsletter. We have 2 newsletters, one for infertility and one for adoption. They both come out once a week. We let you know about the latest developments in infertility as well as the upcoming week's blog and show topics and whatever new resources we've added to our site that week. We'd love to have you on our list. We value privacy and never share your address with anyone. You can sign up for the weekly newsletter at the top right of any page of our website, creatingafamily.org. We have a question that we received from someone. She says, my husband has male factor infertility, low volume, and we have sex every other day during ovulation time. Will doing an IUI mean that we have to forego having sex on those days in favor of him giving a semen sample for the IUI procedure? Having a normal sex life during infertility is hard enough. Please say that there is an advanced capture and release program for his boys so that our sex life is not obliterated. That's the fact that, as she points out, having a normal sex life during infertility is hard. So how does, for someone who would like to be having sex every other day during their ovulation time, is that still possible if you are doing sperm samples for IUI?
So generally it is recommended that the male abstain for 2 to 3 days prior to the collection of the specimen. That being said, I'm not sure how much of an effect that truly has on the chance of success. And certainly we at times do IUIs back-to-back, and it's not always the case that the specimen on the second day is lower or worse quality than the first. In fact, often it's better than the first. So I have my personal, it's kind of interesting. So I have my personal doubts that sort of rule or guideline of 2 to 3 days of absence is absolutely necessary, but it certainly is currently the recommendation. So for a couple who doesn't want to stop having intercourse during that time period, or perhaps their partner happens to be traveling or other things like that, we can, and most fertility clinics can freeze or cryopreserve a specimen in advance of the IUI day, and then it's just thawed and used for insemination when the time is right.
And do you see a difference in the quality of the sperm sample if it's been frozen versus fresh?
A small decrease in the quality, or not the quality so much as the concentration. So if you're starting off with a good concentration anyway, it doesn't really matter. But if a particular partner has a borderline concentration, then it's probably better to use a fresh specimen as opposed to a frozen one.
Gotcha. Okay, now I want to kind of switch gears here and talk about things that couples who are going through a artificial insemination can do that might give them a slight edge. I would be interested to know if any of these would be significant, and some of the lifestyle ones might be. But tips for people who are trying to conceive. Let's start with foods. Are there any suggested foods that you're getting ready to do an IUI, it's coming up in the next couple of months, things that you should be focusing on or your partner should be focusing on eating or avoiding?
Absolutely. So this is actually a very common question among my patients. I think it's something that people can really kind of wrap their minds around and something that they have control over, which is kind of a unique feature during fertility care where a lot of things are outside of a patient's control. So I do get this question a lot. And actually the answer is not that complicated. It's sort of what doctors have been recommending for eons, that a balanced diet is recommended. Some will lean towards a more low-carb diet, especially in women with polycystic ovarian syndrome. Try to avoid excess sweets and fats, but eat a healthy but balanced diet. Obviously, alcohol, too much caffeine, those kinds of things are to be avoided. But at the same time, we don't want patients to lose complete control of their lives or have no fun during fertility treatment. So, a glass of wine from time to time is okay. Certainly after the artificial insemination, while you're waiting for the pregnancy test, I would discourage alcohol intake. But during this cycle and leading up to that, it's okay to lead a normal, healthy lifestyle.
Okay, so just our standard balanced diet, a variety of foods, aiming for a lot of different colors in your food. What about protein? What is considered the optimum amount of protein to be consuming?
So again, there isn't an optimum amount per se. In women that have polycystic ovarian syndrome, it is better to increase the protein intake and lower the carbohydrate intake. But exclusively ingesting protein, sort of in an Atkins diet style, would not be good either, as that does have effect on sort of the general chemistry within the body and wouldn't be ideal in a person attempting conception. It's better to kind of stay at the top of that bell curve in the normal range of all carbohydrates, proteins, fats, that kind of thing.
Okay, so we've talked about diet. What about other specific lifestyle choices that people can make that might make their the IUI be successful versus having to go through the procedure again and again? So lifestyle issues.
Absolutely. So again, I think the main focus should be on balance and well-being. So continuing with exercise is fine, although I wouldn't probably start training for a triathlon during the typical IUI cycle. It is fine to go for walks and maintain a normal exercise regimen. Also, again, getting out and doing things that you enjoy to have things other than fertility kind of on your mind are important. So keep going out with your friends, go out with your husband. Don't make the fertility the sole focus of all of your attention, or it will cause you a lot of stress. And stress is probably not the best or most helpful condition to have while trying to conceive. Acupuncture is something else that people have tried. There's no data to suggest that acupuncture has a profound impact on improving pregnancy rates, but it certainly does help patients deal with the diagnosis and the treatment involved in infertility much better. And there is mixed results relating to how the degree to which it actually does improve pregnancy rates.
I was going to ask about what have you been seeing? It's something, this area I'm interested in, and we've done a couple of shows, but I haven't seen anything recently from the research standpoint that's talked about efficacy of acupuncture for increasing pregnancy results with IUI or IVF or any form of treatment. Have you seen anything like within the last year or two?
I haven't seen anything within the last year or two related specifically to pregnancy rates, but again, sort of the overall feeling of patients undergoing fertility treatments is better and improved in those that take the time for acupuncture.
Okay, got it. Before we go off of lifestyle choices and move to talking about alternative treatments, what about things like smoking? We know smoking is not good for our health. That, I think, is pretty well established. But has there been anything done that specifically talks about smoking in relation to success for infertility treatment and, in particular, IUIs?
Absolutely. So there's a greater degree of infertility overall in smokers compared to non-smokers. Miscarriage rate is higher in smokers. Pregnancy complication is higher in smokers. Menopause occurs earlier in women who smoke, so there's often an issue related to diminished ovarian reserve in women who smoke. And then, of course, after the baby is delivered, the problems continue, and there's a higher risk of sudden infant death syndrome and asthma in the infant. So whether actually it's the patient herself who's a smoker or the partner is a smoker, it doesn't have a helpful impact on the chance of a conception and then a healthy live birth.
Well, you addressed, you touched on my next question, which is secondhand smoke. So if the woman is not a smoker or has stopped smoking, what about the risk of secondhand smoke?
Right, absolutely. So there's less data on that, although certainly there's less data on that with regard to fertility in particular, although there is significant data to show that secondhand smoke does also impact outcomes of pregnancy. So, you work so hard to have this conception, and then it would be a shame to damage the pregnancy itself through exposure to secondhand smoke, and that obviously applies also after delivery to the children themselves. And one has to imagine that if a patient can reduce her fertility and increase her miscarriage rate by smoking herself, then there's probably at least a subtle impact on inhaling secondhand smoke from a partner.
And when you said pregnancy outcomes, do you mean there's research that would say that exposure to secondhand smoke increases your odds of miscarriage or premature birth?
Preterm delivery, yeah.
Okay.
Yeah.
So preterm delivery is a prominent one. Interesting. Okay. All right. I'd like to take a moment now to thank a few more of our gold sponsors and to remind you that it is through their generous support that we can bring you this show every week, as well as all the resources we provide at Creating a Family. We have the law offices of James Fletcher Thompson. They are a South Carolina firm committed to assisted reproductive law, including providing a gestational surrogacy matching program, as well as legal services for independent surrogacy, egg donation, and embryo donation matters. They also have an adoption law practice as well. We have Nightlight Christian Adoptions. They are a pioneer in offering embryo donation and adoption services to clients throughout the world through their Snowflakes Embryo Adoption Program, and they recently celebrated the birth of their 400th baby. And Fairfax Cryobank. Fairfax has been a leader in sperm donation for over 20 years and is dedicated to supplying updated, verified, and accurate medical and personal information on their donors. All right, let's talk. We'll go ahead and talk about other alternative treatments. We've mentioned acupuncture. What about Chinese medicine, herbs, Chinese medicine, other? Has there been any research recently? Again, we've done some shows in the past on this. And the frustrating thing is that if you talk with Chinese medicine specialists, they are frustrated that the Western approach to research they don't feel like is particularly conducive to teasing out the efficacy of their treatment. But nonetheless, I can't help it. I still have to ask about research. So what do we know about Chinese medicine? Is that worth the while for people who want to give it their all to increase their chances to the highest degree possible?
So I unfortunately don't know that much about the specifics of herbal or Chinese medication remedies for infertility, so would suggest to sort of follow the guidelines of the original provider on that. That being said, a lot of different supplements and herbs may contain hormonal properties. For instance, soy has estrogenic properties to it, and those may affect the progression of the IUI cycle, the development of the endometrial lining. So I would advise caution when supplementing an IUI type of stimulation with other herbs and supplements, as it's unclear what effect they would have on the cycle itself and the ability of the embryo to implant.
And you would certainly want your reproductive endocrinologist to know about what it is that you might be taking.
Right.
All right. And what about meditation?
Absolutely. So the sort of mind-body continuum, I think, is important. Again, there's not a great deal of data out there that I'm aware of to suggest improved pregnancy rates with meditation, but these type of mindful behaviors, yoga and meditation and the like, are helpful in reducing stress for patients who are undergoing fertility treatments, and that can be helpful not only for the success of the cycle, but also for that patient's overall experience, the health of their marriage, the health of their relationship, their attitude towards the pregnancy, and ultimately towards their child down the road.
Let's talk a little about the impact of stress. It's a touchy subject. The reality is being infertile is for most people extremely stressful. Depending on it ranks right up there as one of the most stressful life events. So when somebody is stressed to the max because of a disease, and you tell them that they're not that one of the symptoms of the disease, the inability to get pregnant, is because of the stress, it's kind of a catch-22, and it makes people want to scream or rip their hair out or smack you. So it is a touchy subject. But there has been some research on the effects of stress. So, how does stress impact our ability to conceive?
Right. So there's again not a lot of. I guess the good news is there's not a lot of data to suggest that stress has a profound negative impact on the ability to conceive. So. Even if a woman is very, very stressed out and unable to sleep at night and experiencing mood changes related to that, she can rest assured that despite all those symptoms, at least her chance of pregnancy is probably not profoundly affected. That being said, those types of symptoms certainly would be expected to affect her interpersonal relationships, her sense of self, her potentially her feelings during the future pregnancy that will ensue, and also after childbirth too, to have experienced such a stressful and even sometimes traumatic portion of one's life.
So if I'm hearing you, it's perhaps less of the actual conception other than for your mental health and your enjoyment of life, stress has more impact on that. Is that what am I hearing you correctly?
That's right, and actually that should be somewhat reassuring to patients, I think, that because if people kind of do what they can to reduce their stress in their life, that's great. But even if some stress is there, it's not going to have a big effect on the chance that they will have a pregnancy.
And it's almost, unless you don't care one way or the other, whether or not you get pregnant, it's really hard to say, I'm going to treat this in a non-stressful way. But there are definitely things, and we've got resources, and I know your website too, I am sure RMA New Jersey's website has resources on reducing stress to the extent you can. Let's talk some about supplements. There are a lot of, if you go to health food stores or whatever, or even just look on the internet, there are definitely supplements that are encouraged for people who are trying to get pregnant, both for the male as well as for the female. And since mild male factor is a potential, it can be solved through the IUIs, or intrauterine inseminations, let's talk some about supplements that might be, are supplements effective for mild male factor infertility?
Absolutely. So there aren't a great deal of supplements that have, again, a dramatic impact on the semen analysis, but one of the ones that has been suggested is antioxidant treatment for men with teratospermia, or abnormally shaped sperm. So, vitamin C, selenium, other types of antioxidants have been used as supplements in an effort to improve a man's sperm shape. It's unlikely, again, to have a profound effect in, improving the sample's percent of normal sperm shape by 20% or 30%, but can increase that percentage by a few percent, potentially.
Okay, and that's the antioxidant treatment. Did I hear you correctly?
That's right, antioxidants.
Okay.
One male supplement that is sometimes misinterpreted to be helpful is testosterone. So sometimes men will take testosterone supplements in an effort to improve their sperm count when this is actually giving them the opposite effect. So by taking testosterone supplements, a man will decrease his sperm, sometimes even to an undetectable level. So testosterone is definitely not a good supplement to take.
Gotcha. Okay. And do men take that because of the misinformation of increasing their sperm count or their motility or shape, or are they taking it for other reasons? And if so, what are the other reasons that a man might typically have, reasons that they might have for taking testosterone?
Absolutely. So, so sometimes people do, or men do, take testosterone in sort of a misinformed or for misinformed reasons to improve sperm count. But there is another contingent of male patients who are placed on testosterone because they presented to their primary care physician with lethargy, decreased libido, and other symptoms like that, and they could be tested and found to have a low testosterone level. And when this is the case, testosterone treatment is great. It will help those patients to feel much better. It will give them some of their sex drive back, give them some more energy, just as hormone supplements can sometimes help women who are going through menopause. But if that man happens to be trying to conceive, then testosterone is not the right treatment for him. There are other forms of medicine, for instance, HCG injections, that can improve the testosterone level without decreasing the sperm count. So treatments like that should be considered as first line for men who are still trying to conceive.
Okay. That makes sense. So let's say that's for the men. For a woman, are there supplements that she should be on that would help increase her chances of success?
Absolutely. So there actually aren't a great deal of supplements with definitive proven efficacy. Prenatal vitamins with a good amount of folic acid, of course, are important, not as much during the infertility period as during that early pregnancy and pregnancy period when the fetus is requiring those nutrients for itself to grow and develop appropriately. So prenatal vitamins should be started in the preconception window in infertile women just to build a base of nutrients so that their body is fully prepared to take care of that fetus when, in fact, they do have a conception. The other supplement that has gotten a great deal of press and may have some efficacy is called coenzyme Q10. This supplement would work to improve the energy-producing organelles within a cell, so they help cells produce energy. This, of course, is really important in infertility patients whose eggs and whose embryos are needing to divide and grow at a profound rate. So coenzyme Q10 supplementation may be efficacious. Other supplements have less data behind them. DHEA is one that a lot of women take, although there was a recent article to suggest that it really is not very effective and potentially not at all effective in improving pregnancy rates.
And people are taking DHEA during treatment or before conception. It's the attempt to increase their fertility.
That's right. It's sort of the idea is that it would provide a building block for the hormones that need to be produced during follicle development and then ultimately ovulation. But there was a study recently, which was fairly large, that suggested it does not help improve fertility.
I was just going to ask if is it a large enough study for that we would warrant us paying attention?
Yes, and I'm trying to remember the authors, and I can't just now, but I could get back to you with that. Yeah.
Well, you know what? Do me a favor. I'll try to remember to send you an email asking, and we'll link it in the blog tomorrow for people. Okay.
Great.
So coenzyme Q10 possibly is effective, although we're not certain the degree of effectiveness. But DHEA, probably not that effective. Is that kind of the summation of what you were just saying?
That's right, exactly. And there are other supplements that you might take during a cycle under the supervision of your physician. One of them is growth hormone, but the efficacy of growth hormone is also debated. It's only available by prescription. It is injectable, and it's quite expensive, and you would only want to take it during a certain part of your cycle. But that is another supplement that has been looked at.
Yeah, it's an area of interest in research, and I'm hoping there'll be some more at the American Society of Reproductive Medicine conference coming up in October, because we get a lot of questions from people, and I think you alluded to it probably when we were first talking about, we shifted and talked about things that we can do to increase success. For a lot of people, everything about infertility feels out of their control. So I think that's one reason there is a great deal of interest in the patient community, because this is like one thing that they can do. Give me a pill. Give me something to tell me what to eat. Tell me what not to do. Tell me a supplement to take, because it puts a little bit of control back in. So I so get that. I get the need for that.
Absolutely.
We have come to the end of our time together. I so appreciate this show. Thank you so much, Dr. Marcy McGuire, for being our guest today. Audience, if you have enjoyed this show and want to help us grow, do us a favor and give us a rating on iTunes. We are ranked as the #1 show in these topic areas by iTunes, and by far we're the #1 ranked show, and we really want to continue to keep our place there. It also helps others find us, so it's kind of a win-win across the board. So you can go to iTunes, type in the words Creating a Family, and you can give us a ranking there, or you can go to our website, the radio page, creatingafamily.org/category/radio-show. That's a long URL, isn't it? And you can click on iTunes there, and it will take you straight to the ratings page. It's a star rating, really easy to do. If you want to participate in a discussion on the topics of this show, you can check out my blog tomorrow at creatingafamily.org/blog. Also, to get more information about Dr. Marcy McGuire or RMA New Jersey, you can go to their website, which is rmanj.com, or you can go to our website. They have been one of our wonderful long-term sponsors, and their logo is on the right-hand page of all of the pages of our site, and you can click on their logo, and it will take you directly to there. Thank you so much for joining us today, and I will see you next week.
Your hands were made for greatness. Mighty hands for painting, paneling, and clicking the Submit Order button on HomeDepot.com to get that duvet. And these Egyptian cotton towels delivered right to your door. Do more with decor at the Home Depot. Save up to 30% on select bedding and bath. Now at HomeDepot.com. More saving, more kinds of doing. Valid on select items online only. Free delivery on select items $45 or more. Enter promo code BEDBATH15 at purchase for an extra 15% off. Visit HomeDepot.com for more information. Your hands were made for greatness. Mighty hands for painting, paneling, and clicking the Submit Order button on HomeDepot.com to get that duvet. And these Egyptian cotton towels delivered right to your door. Do more with decor at the Home Depot. Save up to 30% on select bedding and bath. Now at HomeDepot.com. More saving, more kinds of doing. Valid on select items online only. Free delivery on select items $45 or more. Enter promo code BEDBATH15 at purchase for an extra 15% off. Visit HomeDepot.com for more information.